Hi, I'm Aleena CrisLivingston, and my research proposal is on alpha particle radionuclide therapy on prostate cancer, and my supervisor is Dr. Jake Hendrick. And the title of my research is Targeted Alpha Particle Radionuclide Therapy in Prostate Cancer, a systematic review of therapeutic potential, biomarkers, and future directions. To begin with a brief background, in 2025, prostate cancer is the most commonly diagnosed cancer for males, and it is the second most common cancer when it comes to the death. While mortality rates have been decreasing, number of deaths of prostate cancer continue to rise, and it is mainly because of the population growth along with the aging of the population exceeds the reduction in age standard. The highest mortality rates to result in the increased number of deaths of prostate cancer. And PSMA represents a well-established molecular target due to its high expression in advanced prostate cancer, and its limited expression in the normal tissues. The advantages of PSMA include high tumor to background contrast, internalization after binding, and excellent correlation between imaging uptake and therapeutic response, and the personalized dosimetry capability. The therapeutic radioisotopes include actinium and lutetium, and diagnostic radioisotopes includes gallium and fluorine. And the alpha particle radionuclides include thorium, radium, actinium, bismuth, acetate, lead, bismuth, and terbium. And this concludes the half-life and the current production route, which is the generators, and the potential increase of production can be done through neutron irradiation of radium in case of actinium. And the therapeutic potential of alpha particle radionuclides of advanced prostate cancer. Radium is one of the first clinically trial radioisotope which shows overall, an improved overall survival, and PSMA target alpha particle radionuclide like actinium shows supports potency against resistant disease phenotypes, including post lutetium, and these includes the this positioned alpha therapy as a high potential therapeutic pillar for advanced prostate cancer. And coming into the aims include to summarize the therapeutic potential and to systematically review the preclinical and clinical trials, and to identify the clinical and imaging biomarkers, and to assess the current gaps and barriers, and to identify what's lacking for clinical adoption, and to propose the future directions and recommendations for optimizing clinical implementation and potential integration of alpha particle radionuclide therapy in prostate cancer, and to address the critical need for developing infrastructure and sustainable radionuclide supply chains. So the method included identifying the relevant keywords like targeted alpha therapy, prostate cancer, mCRPC, PSMA, and the search plan was being made, and the results were refined on the database like Scopus, PubMed, Web of Science, and OneSearch, and the duplicates were removed, and the titles and abstracts were screened, and relevant peer-reviewed papers were gathered. And the inclusion criteria include the peer-reviewed literature and preclinical and clinical studies within September 2025, and the studies types included clinical trials, randomized control trials, case series, clinical guidelines, as well as retrospective and prospective cohort studies. And the systematic reviews were usually for the reference harvesting. And the exclusion criteria included non-English case reports and abstract-only editorials, chapters, letters to editors, and commentaries without original data. And the trials were from clinical trials registry. And the significance of this project is prostate cancer is one of the leading causes of cancer-related death, and alpha particles has high LET short-range radiation, which helps in precise tumor killing while sparing the normal tissues. And the clinical adoption is limited by unclear biomarkers, long-term toxicity, regulatory hurdles, and radionuclide supply issues. And this review is unique because it integrates the evidence on approved radium and emerging alpha therapies, correlating its efficacy, safety, and biomarkers to guide the patient selection, which enables predictive and personalized alpha therapy selection and monitoring. And it addresses the lack of harmonized dosimetry and GMP infrastructure and sustainable isotope supply, which supports standardization and equity, ensuring a safe global access. And it also synthesizes the fragmented preclinical, clinical, and translational data processes, toxicity mitigation, and supply chain solutions, which provides a broad roadmap for integrating alpha therapy into standard care treatment of advanced prostate cancer. And this and for radium, there were about 100 clinical trials that were in the registry, and actinium about 15 to 8 to 12, and rest radium is the only one which is in the phase 3 stage, and whereas rest everything is in the phase 1 or preclinical state. And radium 223 marked the landmark of trial that led to the approval of radium in mCRP for bone metastasis. Radium is a bone-seeking modality, whereas rest of the alpha nuclides are PSMA ones. And those radionuclides include thorium, lead, actinium, astatine. And when it comes to the preclinical ones, they were done on mouse and xenografts. And this included actinium, bismuth, lead, thorium, terbium, and the biomarkers includes PSMA PET uptake, and the high baseline SUV mean and tumor to liver ratio predict the strong biochemical and imaging response to actinium and lutetium therapy. And this helps to select the patient which is mostly benefited from it. And then comes the tumor volume and FDG PSMA concordance. The absence of FDG positive and PSMA negative lesions predicts superior response, and it improves the eligibility accuracy. And then there are other clinical covariates like hemoglobin, non-visceral disease, and lower alkaline phosphate predict favorable outcomes. And the other biomarkers include genomic and post-therapy PSMA imaging, which includes early reduction in lesion SUV and tumor volume. The current gaps and barriers of clinical adoption include limited global supply of radionuclide production, which leads to the trial delays and restricted access. And when it comes to the dosimetry, there is not standardized alpha dosimetry protocols, which leads to safety risk and uncertainty in the dose. Then another thing that is to be looked into is the toxicity, which reduce the tolerance and quality of life. A major toxicity found in most of the radionuclides is serostemia. And there are steps taken to reduce it by combination therapies and regulatory framework, which has inconsistent global framework, which leads to the slow approval. So there is a need for a unified good pharmaceutical practice guidelines for the faster pathways, and most of the trials are small and heterogeneous studies, which leads to low external validity. Hence, there is a need for international multicenter randomized control studies for trials. And when it comes to the infrastructure and expertise, there is limited good manufacturing practice and isotope logistics, which lead to slow clinical integration. And training is also need to be given to the people who are working in these environments. And the future directions include a focus on research and trials, which includes dose optimization studies and early line and tandem alpha beta trials, which improves the efficacy and evidence strength. And imaging and dosimetry, there is a need for harmonized PSMA, PRCIT, and dual tracer criteria, which ensures safety and response compatibility. And as discussed before, toxicity mitigation, regulation and quality infrastructure supply, and global access and sustainability is required for the clinical implementation, which promotes equity and long-term supply chain and enable approvals and reimbursements. The challenges and limitations include the clinical trials are a heterogeneity, which prevents direct comparison and complicates meta-analysis, and limited trial scale and design. Most of the, as I said, most of them are small single-center early phase studies, which may cause selection and publication bias. And another one is language bias, because some of the papers were non-English. And it can be partially mitigated by citation chaining. And some of the data were unpublished and incomplete because some of the trials were stopped or terminated, and some of them are of unknown status. And the narrow clinical scope, most of the things were concentrated on radium and actinium, whereas there is very few peer-reviewed papers on thorium, lead, and acetate, which are mainly in the preclinical state. And there are also very few papers on imaging biomarkers, which are for predicting the response and toxicity, despite the importance of patient selection. And there comes the radiobiological complexities and evidence limitations, because most of the data are secondary data, reviews based on secondary data, and hence the quality and heterogeneity of published work affects the results. And to conclude, alpha-emitting radiopharmaceuticals with high elite and achieve DNA damage and tumor control, even if the beta particle like lutetium failure, and it has different challenges like toxicity and isotope supply and dosimetry uncertainty, and predictors of response include strong PSMA uptake, low tumor volume, and dual tracer concordance prediction, superior outcomes. And for the path to translation, we should prioritize biomarker stratified trials, standardized dosimetry, and global isotope protection. And with the coordinated research and sustainable supply, PSMA targeted alpha therapy can evolve salvage option to standard of care of advanced prostate cancer. And since the findings are all from public sources, there is no ethical approval required, and this is the time schedule and the reference.
So, Aleena, are there any questions? I have a few, but I'll throw it at you first. Pleasure.
Thanks very much, Aleena. It's a great presentation and very good topic to choose. Thanks very much, Jake. So you said GMP infrastructure. So could you please explain what is GMP?
GMP. It's the good manufacturing protocols, and it's like it includes how the protocol that is to be followed in the manufacturing place, which also includes good training to the people and prevent leakage of and radiation protection and all. And manufacturing should also be done in such a way that it is readily accessible to the people. Yeah.
You mentioned toxicity for alpha emitters.
Yeah.
What type of toxicity?
So main toxicity found is like serostemia, and others include hematological toxicities and renal toxicity.
That's into an okay.
I'll just throw to anyone else first.
Anyone else?
Question. Martin, yes.
Yeah, thanks, Aleena. That was terrific. One thing you didn't mention was waste material. I assume these isotopes are fairly short-lived, but is handling of waste required, or is it an impediment to using this treatment?
So Martin asked me about the waste. So you mentioned the half-life of these radioisotopes are really short half-life. So do we need still waste management?
Yeah, truly. Yeah, waste management is required because as much as production is increased, there is chance of more accumulation of waste. So it is to be dispensed, like it is to be mitigated. Yeah.
And all of these alpha emitters, they don't is unstable or stable, active or inactive. At the chain of reactions.
Yeah.
Then they decay to be active radioisotopes or isotopes just
Actually.
active.
Yeah.
That's maybe the answer because the
Yeah.
daughter is still active and we need to still probably.
Yeah. Like for it is one of the there is frequent doctor diffusion, which also leads to like off target toxicity, which is mainly because of the doctor nuclides.
Thanks, Martin. I'll jump in with a question then. So on slide 17, you mentioned imaging biomarkers. I know that at least some of those studies are referring to lutetium and not actinium. So are there any studies that have looked at total tumor volume, for example, as being prognostic for any alpha particle emitters?
The thing is, most of the biomarkers for alpha particles, the paper is very limited. I couldn't find like exactly pointing out to actinium like alpha particles. So it's like a combination of lutetium and things. That's the papers that I can.
Okay, so but that's only the first one, right?
Yeah.
That's which is PSMA PET update, which is SUPB.
Yeah.
So like how many patients are we looking at for that paper, for example? Not sure. Okay. Because yeah, I don't think there's been any studies on PSMA total tumor volume and how that predicts outcomes in alpha particle emitters, which is good because that's something you can mention.
Yeah.
Right? You can say that it hasn't been investigated and we need to know more about it.
Yeah. But the thing is, in some of the papers, it does state actinium and alpha particles, but not like specifically. But yeah.
I'm not sure I get what you mean. Sorry.
So it's like in some of the papers, it mentions about when it states about the biomarkers about the alpha particle, like alpha radionuclides as well.
Oh, you mean it just mentions them in the paper?
Yeah, somewhere in the paper.
Okay.
Like
Yeah.
when it's stated up. Yeah.
I'm not sure that's relevant.
Yeah.
Like, it would only matter if they had actually been treated with an alpha particle emitter, right? Like not whether they've mentioned it in the paper. I mean, presumably lots of papers would have treated patients with lutetium and then said, oh, potentially alpha particle emitters might have increased tumor toxicity. Okay, thank you. Excellent. I think that's all for questions. Thanks, Aleena.